Hello, wonderful staff of the famous Northwest Kidney Center, the best dialysis provider in the modern world. Today we're going to talk about preventable errors in dialysis units. Of course, I want to begin by acknowledging that we are all human, and therefore all of us make errors. I have made all of the errors we will talk about today and then some. But the point of mistakes is that we learn from them so that we don't repeat them, and hopefully by discussing some of these common errors, you can avoid ever making them in the first place. My talks always seem to have three objectives, and today is no exception. I want you to understand the common errors that occur in dialysis units, recognize their potential complications, and appreciate strategies to avoid common mistakes. The common errors that I chose to discuss today include dialysis line reversal, compromise of sterile technique, needle dislodgement, access infiltration, the use of the incorrect dialyzer, needle stick injuries, dialysis disequilibrium, falls, either hypo or hypertension, alarm fatigue, and administration of intravenous iron too quickly. Let's begin with a discussion of the relatively common mistake of dialysis line reversal. This occurs when you switch the arterial and venous lines, and has happened a few times over the past month at the Kent Northwest Kidney Center unit, so this is a timely issue to discuss. So what does the arterial line do? Well, the arterial line allows blood to pass from the patient to the dialyzer where it is cleaned, and then the clean blood returns through the venous line back into the patient. Now, if the arterial and venous lines are switched, then something called recirculation will occur. So what is recirculation? Well, recirculation occurs when dialyzed blood returning through the venous needle re-enters the dialysis or the extracorporeal circuit through the arterial needle rather than returning to the systemic circulation. So basically, the re-entry of dialyzed blood into the dialysis circuit reduces the solute concentration gradient across the dialysis membrane. It mixes already dialyzed blood with undialyzed blood, and that reduces the efficiency of dialysis. Now, dialysis line reversal can occur using a fistula or a graft or a catheter. If you switch the arterial and venous lines when needles are being removed, then essentially you suck up the same blood from the venous line back into the arterial line, and you end up cleaning the same volume of blood over and over. And of course, this compromises the efficiency of dialysis so that waste products are not efficiently removed. And this can lead to multiple complications, including the accumulation of waste products in the blood that cause symptoms, and that's what we call uremia, and an elevated blood potassium level, which in turn can lead to arrhythmias and even death. With a catheter, if we're unable to aspirate from the arterial lumen, we often have to switch the arterial lines by necessity, in which case it's not an error. It's only an error if we do it unintentionally. But you should know that this maneuver also leads to recirculation on the order of 5 to 25%, depending on the study. And if switching the arterial and venous lines occurs repeatedly, then we need to think about either administering TPA to break up any clots or fibrin in the catheter, or consider just replacing the catheter. A second common error in dialysis units is compromise of sterile technique. Infection remains a leading cause of death in the dialysis population, second only to cardiovascular disease. In addition, infections account for a major share of hospitalization among dialysis patients. So that's why it's so important to strictly adhere to hand hygiene, the use of appropriate personal protective equipment, say when we're putting a patient on the machine, and maintaining aseptic or sterile technique, say when we touch the dialysis machine, to substantially reduce the likelihood of a bacterial infection. There is significant potential for harm if we don't follow infection control practices. Very important to wear a surgical mask, a face shield, and clean gloves when working with a patient's access. And of course, hand hygiene, the act of cleaning your hands with soap and water or using alcohol-based hand sanitizer is incredibly important. When should you sanitize your hands in a dialysis unit? before touching a patient, say the vascular access, before any clean or aseptic procedure, such as accessing a dialysis catheter or preparing IV medicines. After you've been exposed to bodily fluid, like you handled a used dialyzer or you performed a dressing change, and after you touched a patient, say when leaving a dialysis station after removing the gloves, and finally, after touching the patient's surroundings. So after you touch the dialysis machine or after using a chairside computer for charting. Of course, it's important to educate dialysis patients on proper hygiene procedures. We should remind them to wash their access site every day. Of course, wash their access site before every dialysis treatment. They should not scratch their access. It's a common phenomenon among dialysis patients. Obviously, fingernails can be a source of infection. They should be reminded not to touch the access area after it has been cleaned with chlorhexidine by staff. Of course, they shouldn't cough or, heaven forbid, sneeze on their dialysis access during the treatment. And always wear a clean glove or gauze pad if the patient's holding his or her own access site after the needles are removed. Just a general reminder for the nurses and technicians out there, after you have sterilized the dialysis fistula graft, it's very important not to touch the sterile area, even if you were wearing gloves. It's very tempting to palpate the vein prior to insertion of the needle, but the gloves we use are not sterile, and by touching this skin, we contaminate the sterile cannulation area and potentially introduce bacteria. So whatever you do, don't touch the skin after applying the chlorhexidine, because that is a common error in dialysis units. And finally, as part of overall infection control measures, regular monitoring of appropriate hand hygiene practices is really central to successful outcomes of infection control at any dialysis facility. So all dialysis staff, including physicians, should be regularly observed and personnel provided with timely and helpful feedback. It's important to engage patients in this as well. So we want to create a culture in which everyone, including the patients, is encouraged to speak up and contribute to the maintenance of safe hygiene practices. The third preventable error I'd like to discuss is venous needle dislodgement. Venous needle dislodgement during dialysis, it's uncommon, but it is a potentially lethal accident or error in a dialysis unit. The average adult has a total blood volume of about 5 liters, and at standard blood flow rates of 350 to 400 milliliters, can lose anywhere from 600 to 1,000 milliliters of blood within a few minutes and develop hemorrhagic shock. The actual incidence of venous needle dislodgement is difficult to estimate because of underreporting, but in 2005, one researcher estimated that there were about 400 serious adverse events from needle dislodgement occur per year in the United States, with a 10 to 30% mortality rate. So why does venous needle dislodgement occur? This was looked at in a study published by Matos in 2017. It was a prospective, descriptive, observational study of 4,700 dialysis patients from 37 dialysis units. In 2017, there were 136 needle dislodgement events involving many treatments and 118 patients. And the main causes that they found were restlessness and mental confusion or disorientation. Of course, working with a restless or confused patient is just part of our job. So we have to have protocols and procedures in place for preventing needle dislodgement. These include skin preparation. Really want to get all the oil off the skin so that the tape sticks properly. You want to employ correct taping techniques, including the chevron taping configuration. You want to replace the tape whenever needles are repositioned. Now, regardless of the cause of needle dislodgement, it's important to understand that the reason why it's so important for access to be exposed during dialysis is so that you can see the needles. If the needles are exposed and not covered by a blanket, it is much easier to promptly recognize when they have become dislodged. Fourth preventable error in dialysis units, access infiltration. So what is an infiltration? Infiltration means that the needle has been dislodged from inside the vein or graft during either needle insertion or during a dialysis treatment. blood leaks outside of the fistula graft into the surrounding tissues. And this can cause swelling and pain in the area. It may appear bruised, swollen. The area may feel firm to touch because of the blood underneath the skin. And it can occur at any time, basically during needle placement or during dialysis if the needle wasn't secured properly or if the patient moves, particularly if he or she temporarily stops dialysis to use the restroom. Prevention of infiltration involves proper needle placement following the same direction as the vein, proper securing of the needle with dialysis, discouraging people from using the restroom during dialysis, the less they move the better, and finally coming up with creative reminders for the patient, particularly if he or she is confused, not to move his or her arm during the treatment. This may include just some tape across the hand so that they're aware that they shouldn't move it. If an infiltration is experienced, we apply ice, and sometimes we need to rest the access. Okay, preventable error number 5, use of an incorrect dialyzer. Approximately 14% of errors in dialysis units are related to mistakes with the dialysis prescription, including dialysate and filters. So in the old days, using the wrong filter was a very big deal because we used to reuse dialyzers. That is, we would clean the dialyzer after each treatment and reuse it for up to 40 treatments. From an infectious disease standpoint, it was a big mistake to give a patient someone else's dialyzer because you would potentially expose him or her to infections from another patient. These days, however, we employ single-use dialyzers, and so there's no concern that we're exposing a patient to someone else's blood through a previously used dialyzer. Typically, the worst that happens is that someone who uses an F180 dialyzer gets dialyzed with a slightly smaller F160 dialyzer, and so the clearance for that treatment is slightly diminished. That said, if a patient previously had something called a dialyzer reaction, then using the wrong dialyzer could be serious. What is a dialyzer reaction? There are two types of dialyzer reactions, A and B. Type A dialyzer reaction occurs within the first few minutes of dialysis and is probably due to a reaction to chemicals used to clean the dialyzer, such as ethylene oxide, or due to bacterial contamination. Mild reactions may include itching, flushing, wheezing, abdominal cramps, chest pain, back pain, nausea, vomiting, fever, and chills. But a patient can have more severe reactions, including hypertension, dyspnea, cardiac arrest, and even death. Type B reactions are common and less severe. Symptoms typically occur within the first 15 to 30 minutes of dialysis initiation, and they can include chest pain, back pain, nausea, vomiting, hypotension. They are thought to be mediated by a part of our immune system called complement. So if a patient had a type A or B dialyzer reaction with, say, the standard F160 dialyzer, and then they were switched to a different dialyzer, say a Revaclear dialyzer, but then was dialyzed again with the F160 dialyzer, then the reaction would likely recur with a potentially severe complication. So that's why it's very important to always review the dialysis orders and use the dialyzer that is prescribed. The next preventable error in a dialysis unit is a needle stick injury. We talked about this in service last year, but to review, many pathogens can be transmitted to healthcare providers following exposure to blood or bodily fluids. And the most important of these are hepatitis B, hepatitis C, and HIV. Of course, the main occupational risk factor for acquiring a bloodborne pathogen is a percutaneous injury with a needle. Every time you cannulate a patient or remove needles, you run the risk of a needle stick injury. And if that happens, and the patient is known to carry hepatitis B or C or HIV, or if the status is unknown, it's very important to seek medical attention in an emergency department for consideration of something called post-exposure prophylaxis. And that may include antiviral therapy and or, say, hepatitis B immunoglobulin. So what to do in the setting of a needle stick injury? Well, you want to wash the skin with soap and water. It's okay to use alcohol or chlorhexidine, although there aren't any study data to show that this is more beneficial. Regarding prevention, of course, we don't recap the needles. We used to do that in medicine. That was a very bad idea. That's when most injuries occurred. It's important to use a sliding needle guard when removing needles from the axis at the end of the dialysis procedure. The next preventable error that I'd like to discuss is something called dialysis disequilibrium. Dialysis disequilibrium refers to injury to the brain either during or after dialysis because of movement of fluid into the brain as a consequence of the dialysis procedure. So why exactly does this happen? Well, when we dialyze a patient, we remove waste products very rapidly from the blood vessels, so from the circulation. But there are a lot of waste products that are inside of the tissues, and those are removed more slowly. It just takes time for waste products to cross cell membranes, move out of the tissue, and move into the blood. One of the most dialyzable waste products is called urea, clinically measured on blood tests as BUN or blood urea nitrogen. And if you rapidly reduce the urea concentration in the blood with dialysis at a rate faster than urea is removed from the tissues, then the urea concentration in the tissues becomes higher than that in blood. And as a consequence, water by osmosis will move from the blood into the tissues. And this can cause your tissues to swell. And if the brain swell, the skull prevents tissue expansion, and this leads to increased pressure in the brain, which can cause serious neurologic injury. So how does dialysis disequilibrium present? Well, symptoms can be mild and include headache, nausea, blurred vision, restlessness, confusion, or they can be severe, coma, seizures, and even death. The most likely time that dialysis disequilibrium will occur is when a person first starts dialysis. And this is why the nephrologist generally orders a low blood flow rate and a shortened dialysis treatment for a new patient. However, it can be seen in chronic patients who miss their regular dialysis treatment. So if a patient misses dialysis, say for a week or something like that, it is prudent to ask the nephrologist if the blood flow rate should be lowered for the first 1 or 2 treatments to avoid removing waste products too quickly. Falls among dialysis patients are common and represent another preventable error in a dialysis unit. Studies show that approximately 1/4 of dialysis patients fall every year, meaning that they're 3 times more likely to fall than the general population, and falls remaining the leading cause of injury, both fatal and non-fatal, among older adults in the United States. There are many reasons for falls, particularly in dialysis patients, including poor posture, muscle weakness, abnormal sensory system, whether it's neuropathy or poor vision, medications, bad footwear, and environmental factors. So what can you do to prevent falls? Well, watch for ice or pooled water, for melted ice on the floor. Make sure that the floor mats, the dialysis centers are flat and adherent to the ground. Education patients about the risk of falls, and if appropriate, recommend an assistive device such as a cane or a walker. How we manage blood pressure during dialysis, whether it's low or high blood pressure, can potentially constitute another dialysis error. Intradialytic hypotension is a very common problem, and in many cases, we are responsible for it. In one study that included 1,100 dialysis patients and almost 45,000 treatments, 75% of patients had at least one episode of intradialytic hypotension. And in some patients, more than 50% of the treatments were complicated by intradialytic hypotension. The most common cause of hypotension was removal of fluid at too fast of a rate. That is, intravascular volume depletion can occur when the rate of removal by ultrafiltration, which is from the vascular space, is greater than the rate of refill from the interstitial space. So in other words, there's tissue fluid that's supposed to mobilize back into the blood vessels, but if we remove fluid too quickly, we don't allow enough time for that to happen and the blood pressure falls. How can we prevent interdialytic hypertension? Well, first we need to frequently reassess dry weight. Maybe the dry weight's too low and needs to be raised. Encourage patient to avoid eating during dialysis. This shuns blood towards the intestines and that can lower blood pressure. Obviously review their medications. Consider holding antihypertensives before dialysis in the patient with frequent interdialytic hypertension. Encourage the patient to limit fluid gain, so limit salt and water intake. And finally, slow down the ultrafiltration rate. It should often be better achieved with a longer dialysis duration. Similarly, the management of very high blood pressure, if not done properly, can constitute a medical error. Hypertension is a nearly ubiquitous problem among dialysis patients. In one study, the prevalence was 86%. Most high blood pressure in dialysis patients is due to fluid retention, so too much salt and water inside of blood vessels, and therefore we lower blood pressure by removing fluid. If their blood pressure is still high despite reaching their dry weight, then their dry weight is probably too high and needs to be lowered. If reaching the target weight is difficult, consider increasing dialysis time or consider an ultrafiltration session, so a SUF run. Now, if a dialysis patient presents with uncontrolled hypertension and leaves with uncontrolled hypertension, we have made a mistake with the dialysis procedure. We did not remove as much fluid as we needed to. More ultrafiltration was needed. The next preventable mistake in a dialysis unit is being subjected to something called alarm fatigue. Alarm fatigue is a syndrome of overriding the alarm without a thorough assessment of the underlying cause of the alarm. Sometimes when multiple alarms go off at the same time or we're really busy on the floor, we silence the alarms without necessarily getting to the bottom of the cause of the alarm. And so we might miss something. And so it's very important that we pay attention to the underlying cause of the alarm. And the last preventable error in a dialysis unit that I'd like to discuss today is administration of intravenous iron too quickly. So this is for the nurses out there. The dialysis techs are off the hook on this one. Obviously, nurses administer intravenous medications during dialysis, including intravenous iron, which is typically given every 30 minutes in small boluses. Sometimes, however, if we administer it too quickly, it can cause the patients to experience nausea, vomiting, malaise associated with its administration. It's not unusual for a dialysis patient to call my office saying, I got really sick again, I got the iron too fast. And so just be careful to slowly administer the intravenous iron over the course of the treatment. Let's review what we've learned today. There are many preventable common errors in dialysis units. These include dialysis line reversal, compromise of sterile technique, needle dislodgement, access infiltration, use of incorrect dialyzer, needle stick injuries, dialysis disequilibrium, falls, improper management of either hypotension or hypertension, alarm fatigue, and administration of intravenous iron too quickly. Okay, time for the monthly quiz. Question number 1, what is the most serious potential complication of dialysis line reversal? That's right, so you can get recirculation, which can lead to poor clearance of potassium, leading to high potassium levels or hyperkalemia, and that can cause an arrhythmia and even death. Question number 2, is it okay to touch the dialysis access, say the fistula or graft, with your glove after the sterilization procedure? Of course, the answer is no. It's very tempting to touch that vein, but do not touch it. The gloves are not sterile and they can introduce bacteria back to the skin. True or false? Slow dialysis is recommended when a patient first starts dialysis or has missed several dialysis treatments. And the answer is yes. And this is because of the potential for something called dialysis disequilibrium. Next question, what is the most common cause of intradialytic hypotension? That's right. Fluid removal at too fast of a rate. So not necessarily too much fluid removal, it's just too fast. I mean, if you try to remove, 2 kilos an hour, you will make the patient hypotensive. Next question, what is the most common cause of persistent hypertension in a dialysis patient? That's correct. Insufficient fluid removal. So if a patient comes in, they're really hypertensive and they remain really hypertensive throughout the run, that's a mistake because we didn't remove enough fluid. Final question, name 3 strategies to prevent needle dislodgement. That's right. So proper taping technique, minimize movement, cleaning the skin properly so that the tape adheres to it, retaping someone if the needles are moved or adjusted, and finally, very important to keep the needles exposed. Do not have them covered by a blanket. This concludes the August 2024 in-service for the Northwest Kidney Center. Thank you for everything you do for our patients. Hope you have a great rest of your summer. This is Andy Brokenbrough signing out until next month.